BOAST 11 Supracranial fractures of humerus in children. Number 1. On presentation, radial pulse, digital capillary fill, function of the radial medial including anterior trochleus nerve and ulnar nerve should be documented. Number 2. Surgery to be done at the day of admission. If nighttime arrival, avoid and delay for the next first case on the normal trauma list. Number 3. Urgent surgery indication is when radial pulse is absent and there is impaired perfusion of the hand and digits or skin integrity is threatened. Number 4. Cross pins are more stable, but there is chance of nerve injury. Divergent pins reduce the chance of ulnar nerve injury. Number 5. Techniques to avoid ulnar nerve injury should be avoided if medial pinning is planned. K-wire size should be 2 mm. Cubitus superior should be avoided. Bowman angle should be the same as contralateral side. Number 8. Transient neuropraxia is common after postoperatively and does not need operative intervention. Number 9. Vascular impairment post-reduction. If there is a perfused limb, they do not need exploration, whether or not the radial pulse is present or not. Number 10. On-call vascular surgeon if ischemic limb. Number 11. Post-op X-ray within 4 to 10 days post-op to check for reduction. KY removal 3 to 4 weeks. Routine follow-up is not required. BOAST 12, the management of ankle fractures. This has been accepted by BOA and BOFAS, British Orthopaedic Foot and Ankle Society. Number 1. When a patient arrives in the ER, skin, circulation and sensations should be documented. Number 2. Comorbidities should be documented, especially diabetes mellitus, mobility impairment, peripheral neuropathy, peripheral vascular disease, osteoporosis, renal disease, smoking, and alcohol abuse. Number 3. Urgent splintage should be indicated unless X-ray cause unacceptable delay. Number 4. Neurovascular assessment should be repeated after reduction. Number 5. Uncertain stability in a fracture, follow up within 2 weeks. X-ray advisable is full weight bearing if possible. Under 60 years of age, early fixation, the day of admission or the next day, operative intervention should be done. External fixation are rarely indicated. More than 60 years, if the mortise is reduced, put a close contact cast and manage conservatively. Number 8. Allow weight bearing as tolerated in splint or cast unless the fracture is unstable or any other concerns. Number 9. Always follow up till 6 weeks. Number 10. Clear advice regarding resumption of normal activities like work and driving should be given, and a self-referral to the fracture services if progress is not anticipated should be provided. Number 11. Trauma prophylaxis after assessment should be followed and agreed and should have local protocols. BOAST guideline number 13, rehabilitation and communication with trauma patients. Number 1. Rehab prescription should be given within 24 hours. Number 2. Rehab prescription consists of diagnosis, treatment, management, discharge plan, medications, trauma prophylaxis, expected and goals, therapies needed, outpatient visits, and referral, including psychological support. Number 3. Designated coordinator in each unit is available, who is responsible for communication and liaison. That coordinator should be relayed to the patient and relatives within 12 hours. Face-to-face meeting with the coordinator should be expected within 12 hours. Number 5. Patient should be given expected time to return to the previous function. Number 6. Complex care identification and contact should be done within 12 hours post-discharge to review and discuss the proper care and progress. BOAST Guideline 14. The management of urological trauma associated with pelvic fracture. Number 1. There should be agreed guidelines regarding treatment of urethral trauma with pelvic fracture. Number 2. When a trauma patient pelvic injury comes, perineal, genitalia and rectal examination should be done. Number 3. If a single attempt to catheterize, even if the clinically or CT has a urethral injury and with the experienced doctor, should be attempted. Number 4. Blood-stained urine, retrograde cystogram via catheter should be done. Number 5. Urethral bladder injury, a proper referral system should be in place. Number 6. If you can't pass a urethral catheter, pass a suprapubic catheter via Seldinger technique under ultrasound. Skin incision should be in the midline, 3 to 4 centimeter breadth above the pubic symphysis, and a 16 French Foley should be used. Number 7. Urine leak from the bladder or urethra. Treat the pelvic fracture as a long bone open fracture. This means you have to give antibiotics for 72 hours and early fixation if the patient physiology allows. Number 8. Intraperitoneal rupture. It needs emergency laparotomy. Extraperitoneal rupture needs catheter drainage mostly alone. If you are fixing a fracture, then you have to fix the bladder extraperitoneal injury as well. Number 9. Pediatric urethral injuries are more complex and a pediatric urologist should be involved. Number 10. Primary urethral repair indications are: Number 1. Anorectal injury. Number 2. Perineal degloving injury. Number 3. Bladder neck injury. Number 4. Mass bladder displacement. Number 5. Penetrating trauma to the anterior urethra. Number 11. With conventional urethral rupture, treatment should be delayed for at least 3 months. Number 12. An orthopedician should avoid urethral repair while doing pelvic fixation. Adequate, sufficient, optimal fracture fixation after reduction is sufficient for the healing of the urethra. Number 13. Andrological services should be provided for every patient in the unit. All these injuries and their treatment is considered as part of TAN. TAN indicates Trauma Audit and Research Network. BOAST Guidelines 15. Management of blunt chest trauma. 1. A consultant-led team. Anticipated treatment should be done. The injuries can be having severe hemorrhage, respiratory compromise, hemothorax or pneumothorax or other life-threatening injuries. Number 3. CT scan and contrast if chest injury is there or suspected. 3D rendered images within 24 hours if there is rib fracture. Number 4. Agreed analgesia protocols including neuraxial anesthesia or an opiate should be given. More than 48 hours air leak should be discussed with thoracic surgeon. Referral should be indicated within 48 hours. These all injuries are part of TAN, Trauma Audit and Research Network.